So we are live in three, two, one. We are live now, sir.
Good evening, doctors. I
Good evening.
welcome you. I welcome you all to tonight's webinar titled Cannabidol, New Vistas for Neuropsychiatric Disorders. I would like to begin by inviting the moderator, Dr. Shobit Garg, who would introduce the chairperson, esteemed Dr. E. Mohandas, for this evening program, and in return would introduce the speaker, Dr. Chittaranjan Andrade. Dr. Garg is currently Professor, Department of Psychiatry, Sri Guru Ram Rai University in Dehradun, and is an alumnus of CIP. He has held esteemed position as Chairperson, Neuromodulation Committee, IPS Convener, Social Media Subcommittee, SARC, and co-chair IPS Suicide Helpline in the year 2021, apart from being apart from many other distinguished positions both at state and national level. He has won many awards and citations and has authored more than 65 plus publications, both in national and international journals. His area of interest is bipolar disorders and brain stimulation. He's a member. Without much ado, I hand over to you, sir, to take the forward.
And thank you. Thank you to the organizers. So it's my pleasure to welcome everyone in this very special session and amidst the two legends in psychiatry. And I've got this pleasure of introducing Dr. E. Mohandas sir, who's a senior consultant psychiatrist. We always look forward to him. He is a guide, mentor, and someone who has actually motivated us and to read and actually rediscover ourselves with a lot of motivation with 4 decades of experience. And sir has the repository, sir is the repository of psychiatric wisdom, a walking encyclopedia, I would say. Sir, everyone knows sir that he's a former president of IPS and IPP, and biological psychiatry is the special domain in of the sir. So I think with these few words, and actually sir doesn't need any introduction, I would like to hand over the session to Dr. E. Mohandas sir. Sir, thank you, sir. Please welcome, sir.
Shobit, can you hear me?
Yes, sir. Yes, sir.
My job is twofold. One is to introduce my friends, one of the best brains in India, psychiatric brains, Dr. Chittaranjan Andrade. You can see the biodata, more than 700 publication, and he's a researcher par excellence. I know him since law, and his areas of interest basically on ketamine, not only psychopharmacology. And you ask anything, and he will be able to add. That is one part of the story. Second part of the story, he's supposed to speak on cannabidiol. Can I just talk about it for 2 minutes?
Yes, sir.
Can I just talk 2 minutes for cannabidiol?
Yes, sir. Yes, sir.
Chittu will cover everything on cannabidiol. But as we know, we have got excellent panelists. But as you well know, almost 12,000 years ago, the cannabis plant was drawn, and especially from Sumerians. But the medical use of cannabis was in 1831, specifically Oshoganazi and Moriarty tool, that is the medical use of cannabis. And later, 1948, the discovery of tetrahydrocannabinol came, but almost 20 years later, the chemical structure was isolated by Gavoni and the good father of endocannabinoid system, Metolam. Metolam is a Bulgarian born, but he is based in Israel. And he has written so much on endocannabinoid system, a book also, which fortunately I do have. This structure was developed only in 1964. But if you know very well, 1990, CB1 receptors was identified. 1992, anandamide, AEA, or anandamide, some people say, and 1993, it was the cannabinoid receptor, and 1995, 2-acyl glucagon, and then the enzymes in 1997, FAA and MADL, and 2001 only, they have found out endocannabinoid signaling. It's a retrograde signaling that is usually we get it from the presynaptic, postsynaptic. Here it is from the postsynaptic to the receptor. So that's called retrograde. And later in 2008, CB1 receptors were identified in astrocytes. Later in 2012, it was identified in mitochondria. And as you pretty well know, it is called 2P, cannabinoidiol. That is basic history. And around 120 cannabinoids are there. Out of this, most important is anandamide and 2-AG. I will not go into any of the detail of the enzymes, but plenty are there. The true ones, at least half a dozen, the major endocannabinoids, ligand, and also the containers. If you want to read in September 2023, especially Chitu will be knowing pharmacology, that pharmacological reviews, beautiful review had come. And then also in 2023, brain research, etc. And many people feel this is one of the systems which has got effect on almost all neurotransmitters, whether it is glutamate, whether it is GABA, whether it's serotonin, whether it's almost all receptors. I will not go into details, but basically, endocannabinoid system is consist of three. One is the endocannabinoid, which is 2-AG and thing. Then you have got cannabinoid receptors and the enzymes. Now the research in this thing, it was even given for intractable diseases long back in British Pharmacopoeia, but then it was taken out. But current interest has come in cannabidiol, which is supposed to be not, it is a psychotropic rather than a psychotogenic THC terpenoid that is supposed to be psychogenic, but the other one is not. Recently, it was approved, especially fast track approval for intractable problem in epilepsy childhood. That's almost like a desperate remedy. This is called fast track submission, and also orphan drug description, because many of the orphan receptors are de-orphanized. When we talk about cannabinoid system, I will not go into details. Now, the Lennox-Gastaut syndrome, Dravet's, and also tuberous sclerosis complex, I call it desperate remedies, and even they are intractable, difficult to treat diseases, and neurologist is there, Agarwal is there. But response is better, especially treatment refractory diseases, especially 40% will be improved. So the dosing is a little bit different. I will not go into details. And even in psychiatric disorders, there are some suggestions, but most of them are face-to-face trials. But we do have case reports and some systemic reviews, whether it is autistic spectrum disorders, whether it's an early psychosis, whether it is in BPSD or NPSD, neuropsychiatric symptoms of dementia, pain, intractable chronic pain, etc. But the problem is very difficult to tease out very few literature. It has to be less than 0.3% tetrahydrocannabinol. Otherwise, it can have a when psychotogenic effect. But the problem, recent trials now they are undergoing is 20:1 in some of the intractable cases that is underway. I will not comment much on it. Where is the result of this localization? Uh, but most important, CB2, especially cannabidiol, has got some other function. For example, it has got effect on the metabotropic glutamate receptors. That is why early psychosis, and then which type 5, and also it has got especially anti-inflammatory properties. That is why it is coming off the way because storage is basically in immune system and others. Chitu might be talking or we will be discussing later on. I think I have talked enough. Chitu is the best person to talk. Why I talked about it because I had done the talks on endocrine system, endocrine medicine, neurology, endocrine medicine, psychiatry, and I think 6 years back we had a conference in Rome where Rajesh Takpal was there with me only on cannabinoid. The thing I had to moderate the session for half day. Uh, but cannabinoid oil, cannabinoid, the thing that has come in schizophrenia, etc. But evidence is very poor. But he is best authority. I can explain also why this is happening also, but Chitu is the best person. Back to Shobit. But Chitu, I have introduced back to Shobit. You can suggest, can I invite him or anybody to come in? Shobit, you can take the.
Yes, sir. Please, sir.
Yeah.
So please,
Chitu,
sir.
you can go ahead if you please. Will it be all right?
I'm trying to share my screen. Can everybody see my screen?
Yes, sir.
Yes.
And can you hear me clearly?
Yes, sir.
Yes,
Yes.
man.
If any time you cannot hear me clearly or you cannot see the screen, please interrupt me. Well, this presentation on cannabidiol, CBD, is a short presentation, maybe about 25 to 30 minutes in duration. During this presentation, I will provide a bird's eye view on cannabis in general and a little bit on THC, delta 9 tetrahydrocannabinol, because it's necessary to understand the background from which cannabidiol, that is CBD, comes from. This is the outline of the presentation. I will start with a general introduction on cannabis, THC, CBD, a little bit about the general pharmacology of CBD, approved indications, experimental indications, one slide on adverse effects, a few slides on prescription psychopharmacology, because if you're going to prescribe it, you should know things like half-life, drug interactions, dosing, and so on. Now, here is the general introduction. Cannabis is the extract principally from flowers, but also from leaves and other parts of different plants, mainly Cannabis sativa, but also Cannabis indica and some other cannabis species and hybrids thereof, one example of which is skunk. Skunk is a hybrid cannabis plant which is very high in THC. Cannabis goes by a lot of different names. Hemp and marijuana, for example. Hemp actually is technically not the same as marijuana. Hemp has less than 0.3% THC, whereas marijuana has more than 0.3%. Cannabis is also called weed, grass, pot, hash in India, ganja, charas. When smoked as a cigarette, it's called reefers, and so on. Cannabis is used and abused by multiple groups in many different formulations. For example, by the inhalational group, it is used as
So you're not audible, sir?
Yes, yes. Not audible.
You're
Yeah,
not audible.
yeah. Dr. Andrade,
मैं कॉल कर लेता हूँ.
maybe some network.
So you have gone off screen, sir. I don't know. I think you have to log in. Your connection is lost. Your connection is lost.
I think you have to contact Chitu and
Yeah, I have called him, sir.
telephone him and
I have called him. He's actually doing the presentation from Nimans, Bangalore. There is a lot of power cut. Yes, sir. Okay, 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 sir.
hello.
Yes, sir. You're audible. You can share
Am
your
I back?
screen.
Am I back on?
Yes,
Yes,
you're
sir.
back on, sir. Please share your screen.
Give me a minute. Can you see the screen?
Yes, sir.
Is it in full screen mode?
No. Now it is. Now, yes.
Now it
Please go
is.
ahead. Yes, sir. Please go
Is
ahead.
this where I stopped?
Yes.
Shall I speak on this slide again? Because I don't know when I went off.
Yes, sir.
No,
Yes, sir.
I think the
Yes.
Can go to the next slide, sir.
Okay, go to the next slide.
Sir.
So the clinical importance of cannabis is that it has been recreationally used. It has been used as a drug of abuse, and it is currently of interest as a medicinal substance. Recreational use, more than 50% of students in India, as an example, use cannabis recreationally, at least once. As a drug of abuse, for example, cannabis can be associated with medical risks, such as psychomotor slowing and traffic accidents, such as hyperemesis in rare cases, such as respiratory disease, as with cigarette smoking, and with an increased risk of cardiovascular adverse events. Cannabis can also compromise psychiatric health. For example, it's being associated in the short term with impaired cognition, with impaired motivation. Cannabis intoxication can be associated with delirium. Cannabis use in the long term can be associated with dependence and discontinuation with withdrawal symptoms. And cannabis also hastens the onset of schizophrenia, or perhaps can even trigger schizophrenia in persons at risk. But medicinal use of cannabis has been of interest at least for the last 40 years, when cannabis products were first approved for treating hyperemesis associated with chemotherapy or with treatment for HIV/AIDS. Cannabis has also been used in the treatment of chronic pain, in the treatment of spasticity, in the treatment of seizure disorders. Some of these benefits are related to THC, and other benefits are related to CBD. Cannabis is legal in a lot of countries. For example, it's legal in Canada, in the Netherlands, Belgium, Italy, Germany. It's legal in Argentina. In Asia, it's legal in Thailand. In the United States, it's legal in at least half of the states of the USA. In India, cannabis has been illegal under the Narcotic Drugs and Psychotropic Substances Act of 1985, with amendments in 1988, 2001, and 2014. The production, cultivation, manufacture, sale, purchase, production of cannabis, cannabinoid drugs, and other specified drugs under the NDPA Act is prohibited, with punishments outlined for each of these. However, exceptions have been notified for medical or scientific purposes, and CBD comes there. The rules governing the legality of cannabis in India are governed by both center and state. CBD, specifically for use in medicinal contexts with low THC content, has actually been available in India, you'll be surprised, for at least the last 4 or 5 years. It has been marketed not by mainstream pharma, that is what we call modern medicine pharma. It has been marketed by the complementary and alternative medicinal segment under Ayush, and has been available both in stores and online with a prescription that can be very easily procured from the store itself or from an online source. CBD oil was formally approved by CDSCO in India for medical use in April 2023. That's almost a year ago. It is now in the market, as you all know. Now, here are some notes on the general pharmacology of THC and CBD. Cannabis contains more than 550 chemical constituents, which are cannabinoids and non-cannabinoids. The cannabinoids number something like 120 or 130, possibly more, discovered today. The remainder are non-cannabinoids like terpenoids, flavonoids, and others. The really important constituents in cannabis are delta-9 tetrahydrocannabinol or THC and cannabidiol, CBD. If you think of cholesterol as good and bad cholesterol, good cholesterol is HDL, bad cholesterol is LDL. The good cannabis is cannabidiol, CBD, and the bad cannabis is delta-9 tetrahydrocannabinol, which is THC. But I'm going to say a little more about whether good is actually good only and whether bad is actually bad only in a few slides from now. When you read about cannabis and research on cannabis, particularly randomized controlled trials on cannabis, you'll come across a lot of different names like dronabinol, nabilone, nabiximols, sativex, epidiolex, and others. So you should know what all of these are. For this slide specifically, dronabinol is synthetic THC, delta-9 THC. Nabilone is a synthetic cannabinoid, which is actually not the same as THC because it has partial agonist effects like CB1 and CB2 receptors. Now, all major cannabis products contain both THC and CBD. And how much of THC and how much of CBD is there, that is the ratio of THC to CBD, depends on from which part of the plant the extract is obtained. For example, if it's obtained mainly from the flowers, there's a lot of THC there. If it's obtained mainly from the leaves, there is a lot more of CBD and a lot less of THC. Medicinal extracts have been standardized in different concentrations. For example, nabiximols, also known as sativex, is 20:1 THC is to CBD. So it's still mainly THC with a little bit of CBD over there, 20:1. In street sources, the content of THC is progressively increasing so that the psychotropic properties of cannabis are maximized. That is what the street users want. Now, what are the effects of THC? THC is psychoactive. For example, it produces euphoria, it produces anxiolysis during the period of administration, but it also blunts cognitive performance and causes psychomotor impairment, increasing the risk of falls, traffic accidents, and other problems. It increases appetite. It improves sleep at lower doses, but decreases REM sleep at higher doses. It has strong antiemetic action. It relieves pain. It reduces spasticity. Just spend a few minutes thinking about, okay, not a few minutes, spend a few seconds thinking about this. It is psychoactive, but euphoria and anxiolysis in moderation is actually what we want. Now, we don't want the cognitive blunting and the psychomotor impairment, but you take the benzodiazepines, you take the tricyclic antidepressants, you take the antipsychotics, all of them have favorable effects for their respective indications, and all of them cause some degree of sedation, psychomotor impairment, impairment of cognition, and so on. So you see, THC actually has some good properties and some bad properties, and we may want a little bit of THC in the product which we are using. Increasing appetite is bad, but not in all conditions. It can be useful, for example, in conditions associated with, let's say, AIDS and conditions associated with chemotherapy where patients lack appetite, cancer where patients lack appetite, and so on. THC improves sleep, it has an antiemetic action, it relieves pain, all of which are important, and it reduces spasticity, very important in patients with multiple sclerosis. THC acts mainly on CB1 receptors and to a lesser extent on CB2 receptors. Now, what does CBD do? CBD actually does not have psychoactive properties. A patient who takes CBD does not feel euphoric, does not experience a marked feeling of relaxation, does not feel any sensation of, for example, having taken a psychoactive drug. So in a way, this is good because it doesn't impair cognition, it doesn't impair psychomotor performance, it does not have addictive potential, and so on. Also, a proven effect of CBD is that it has anti-seizure action. But if you really want strong anti-emetic action, strong pain relief, strong relief from spasticity, a little bit of THC also needs to be present. More about this later. CBD itself has been shown to have analgesic properties, anti-inflammatory action, which is much more than that of aspirin. CBD has, in some studies, been shown to reduce anxiety, reduce psychotic symptoms, and have other potential benefits, which I will talk about later. Now, just one slide on the pharmacodynamics of CBD, just to point out, as Dr. Mohandas quite appropriately said, that CBD has a very vast spectrum of action on systems in the brain. CBD itself has low affinity for CB1 and CB2 receptors, but can act as both agonist and antagonist at these receptors, depending on the dose. It is a partial agonist at 5-HT1A receptors, which perhaps may have anxiolytic and antidepressant potential. It is an allosteric modulator at mu and delta opioid receptors. And through this action, it may have a calming effect, it may have a relaxing effect, it may have an anxiolytic effect, it may improve sleep. Importantly, it acts on intracellular calcium release through multiple mechanisms, and it increases adenosine signaling, both of which are relevant to its anti-seizure property. And CBD acts on glutamate, and it increases BDNF and the downstream neurotrophic factors, increasing signaling in territories such as the hippocampus, increasing functional as well as structural neuroplasticity in the hippocampus, which has potential antidepressant properties. In India, CBD has been approved as of April 2023 for the Lennox-Gastaut syndrome, for Dravet syndrome, for tuberous sclerosis complex, that is specifically for seizures associated with these three conditions in patients aged 1 year and older. Lennox-Gastaut syndrome is a syndrome characterized by multiple different kinds of seizures. Dravet syndrome is associated with the SCN1 gene. It is also associated with different kinds of seizures, which tend to be treatment refractory. Tuberous sclerosis complex is associated with, when it affects the brain, again with seizures which are refractory to treatment. And as Dr. Mohandas pointed out, when we are desperate, we turn to anything, and CBD oil has been found to be effective in treating patients with these disorders. CBD oil, in fact, was approved in the USA for these conditions in 2018, the seizures associated with the Lennox-Gastaut syndrome and Dravet syndrome, and in 2020 for seizures associated with the tuberous sclerosis complex. Now we come to experimental indications for CBD. Take Lennox-Gastaut, take Dravet, take tuberous sclerosis. All of these are rare. They're not common in the general population, and you would first try a lot of the standard anti-epileptic drugs. So actually, those become niche indications for CBD. There are a lot of other far commoner conditions for which CBD is potentially useful. Here is a list of these conditions. Anxiety, generalized anxiety, social anxiety, anxiety associated with post-traumatic stress disorder, anxiety associated with drugs of abuse, including, for example, cocaine and opioids. CBD has been studied for emotional exhaustion and burnout in healthcare workers. It has been studied in patients at high risk of psychosis, ultra high risk patients, as well as in patients with actual psychosis, both CBD versus placebo and CBD versus a comparator drug like amisulpride. CBD has been found in animal studies to have potential for the treatment of substance use disorders in a lot of different animal models of substance dependence with a lot of different substances. In humans, CBD has been trialed for patients with cannabis use, opioid use, tobacco use, and alcohol use. CBD has also been studied in pain syndromes. And here I want to point out that whereas for the approved indications, dosing is in doses like 2.5 to 25 milligrams per kg per day, in adults, dosing ranges from 300 to as much as 1 gram of CBD per day. Now, Dr. Mohandas pointed out about that the quality of the research is actually a little bit iffy. And he said that I would speak about it, and he's quite right. I have 2 slides devoted to difficulties in interpreting the clinical trial research on CBD for psychotropic indications, for psychiatric indications. Which are the indications? Anxiety, psychosis, substance use disorders, and so on. Most of these studies have been conducted on standardized or unstandardized extracts, which contain more THC than CBD. So we cannot draw conclusions about CBD from these studies. Many of these studies have been conducted on dronabinol and nabilone. Dronabinol, as I told you earlier, is synthetic THC, and nabilone is a synthetic cannabinoid which acts on both CBD1 and CB2 receptors as a partial agonist. Then, most of the CBD studies, I'm not talking now about the cannabis studies, I'm talking about the CBD studies, have been not on pure CBD, but on CBD in combination with THC in varying proportions. For example, there are several studies, such as in autism and other disorders, in anxiety, in psychosis, on nabiximols, which is actually THC is to CBD in a 1:1 ratio. So that's quite a lot of THC over there. And there are a number of studies which are conducted on Sativex. A number of studies which are conducted on proprietary formulations. Sativex is 1:1 on proprietary formulations, which is 5% THC. That is, THC is to CBD is 1:20. Now, even 5% THC is actually a lot more than 5% THC, for the simple reason that CBD inhibits the metabolism of THC and of the metabolism of its active metabolite 11-hydroxy-delta-9 THC. So what this means is that the actual active THC moiety is much more than 5%. So if we are talking about even a 1:20 combination of THC to CBD, we're not talking about the properties of CBD alone. We are talking about the properties of THC as augmented by quite a lot of THC. Why is this important? Because the CBD, which is marketed now in India legally, is actually 99.9% CBD. There is a negligible content of THC and other substances. The purity for CBD is very high. Other problems in interpreting the clinical research is that a lot of the studies, such as on anxiety, on paranoid symptoms, and so on, including on, for example, attitudes towards drug use and effects of psychotropic drugs like cannabis, opioids, and so on, were actually conducted in healthy volunteers. Studies which were conducted in clinical populations were open label or uncontrolled. Many of the studies were crossover studies, where there's a potential carryover effect. Many of the studies were short duration. Some of them were cross-sectional, some of them were maybe 1 week or 2 weeks in duration. Like, for example, a study on tobacco smoking, which had very promising results, was actually only for 2 weeks in duration, and CBD was administered only in the first week. Most of the studies examined minor outcomes. For example, they looked at EEG or evoked potentials characteristic of psychosis. They looked at fMRI in circuits that are relevant to psychosis. They looked at biochemical outcomes. They looked at cognitive outcomes. They looked at subjective outcomes. They looked at minor issues, like, for example, to give you an extreme example, the exhaustion subscale of a burnout rating instrument. Many of the studies were underpowered studies. Very few randomized control trials with a sample size of more than 30 or 40 in the entire study. And I'm not talking about each arm. And most important of all, there were no studies conducted in refractory samples. For example, studies of the use of CBD in patients with anxiety, or CBD use in patients who are smoking or patients who are taking substances, were not conducted in patients who were selected to be refractory to already existing and approved treatments. Now, you can see where the problem lies. It's difficult to draw conclusions about how useful CBD is going to be in a treatment refractory population. After all, CBD oil is expensive, and we're going to try out all the recognized treatments before we turn to something like CBD. So it's difficult when the studies have not been conducted in refractory samples to decide what the potential benefits are with CBD in the refractory samples. Now, I'm not going to present all the studies because there's simply no time. In fact, I think I've already reached my 25-minute limit, so I probably got another 4 or 5 minutes left in this presentation. I'm just going to tell you my general impressions of the clinical data in this single slides. First, the efficacy of CBD against seizures is beyond question. This has been known for decades, and it has been established in randomized controlled trials, which led to the approval of Epidiolex in the USA. And the Indian brands are very similar to Epidiolex in composition, more than 99% purity for CBD. CBD is of unclear benefits for other indications. And I include things like anxiety, depression, sleep disorders, risk of psychosis, intractable psychosis, substance use disorders, smoking, drinking, opioids, cannabis, and so on. There are many studies with negative outcomes, finding CBD ineffective. Having said so, there are definitely studies with positive outcomes, including studies published in major journals. For example, a clinical trial in Journal of Clinical Psychiatry, journals like American Journal of Psychiatry, Lancet Psychiatry, Psychopharmacology Berlin. All of these have published positive results with CBD, that is cannabidiol, no THC content. All of these studies have published positive findings for indications ranging from psychosis to substance use to anxiety and so on. So what is my take on this? My take is that the only way forward is to conduct adequately powered RCTs in clinically relevant populations, studying clinically relevant outcomes. Until such a time, we would have to find our own way through trial and error, experimenting with doses, experimenting with indications in patients for whom conventional treatments have not been of help. Adverse effects of CBD include somnolence, which actually may be a desirable effect in patients in whom sleep disturbance is present, decreased appetite, which actually may be a beneficial effect in patients in whom increased appetite and wake up problems, vomiting and diarrhea, which are dose-dependent symptoms, elevated enzymes, liver enzymes, in a small proportion of patients, also a dose-dependent problem. So, ending my presentation with a few quick slides on the prescription pharmacology of CBD. The oral bioavailability is low. It's only 6 to 10%. The reason for this is CBD is substantially metabolized by CYP3A4, and there's a great deal of 3A4 in the gastrointestinal lining. So CBD gets metabolized even at the time of absorption itself, before it reaches the liver, where first pass metabolism takes place. So actually there are two first pass metabolisms for CBD, one occurring in the GIP lining and the other occurring in the liver. The time to steady state with CBD is 2.5 to 5 hours. Now, here is something which I found a little difficult to wrap my head around. The half-life is something like 2 to 2.5 days, but steady state occurs in 2 to 4 days with twice daily dosing. Not sure how this happens, but this is what I have read in the sources which I have come across. CBD is extensively metabolized in the liver. And so doses of CBD need to be lowered in patients with liver disease. CBD is negligibly excreted by the kidneys, so no dose adjustment of CBD is required, regardless of the severity of renal disease. Drug interactions, this is something that you ought to know. CBD is metabolized by 3A4 and 2C19 to active and inactive metabolites. So anything which induces 3A4, like for example rifampicin or the older anti-epileptic drugs, phenytoin, phenobarbital, carbamazepine, and to a certain extent oxcarbazepine, all of these will diminish the benefits of CBD. So please keep in mind, if the patient is receiving CBD for seizure disorder and the patient is also receiving, say, any of these older anti-epileptic drugs, carbamazepine, oxcarbazepine, phenytoin, phenobarbital, primidone, there is a risk that the dose of CBD would be inadequate and would need to be increased to make up for its induced metabolism. CBD itself inhibits CYP2C19 and other enzymes. Lesser extent CYP3A4, 1A2, 2C8, 9, and some of the UGT, glucuronide transferase enzymes. So drugs such as, say, citalopram, escitalopram, to a certain extent fluvoxamine, some of the other antidepressants, their levels may be increased if CBD is administered to patients who are receiving those drugs. So you can't possibly remember all the drugs which inhibit and which are metabolized, which induce these enzymes. So if at all a patient is already receiving a drug, just check how that drug is metabolized. Just check what that drug induces and inhibits, and check whether CBD is likely to be effective based upon what I have presented to you in this slide. I think this is my last slide. CBD for seizure control is started particularly in children at a dose of 2.5 milligrams per kg per day in the first week. The dose may be raised week by week to a target of 10 to 12.5 milligrams per day, as high as 25 milligrams per kg per day in, for example, seizures associated with tuberous sclerosis. It depends upon the indication, it depends upon the concurrent treatments, whether they are enzyme inducers, enzyme inhibitors, depends on the liver status of the patient and so on. For adults, a fixed dosing regime is more appropriate. A starting dose could be 150 mg per day, raised to 300 mg per day. Holding at 300 mg per day, looking at the benefits, looking at the adverse effect profile, and raising the dose to as much as 1,000 milligrams per day. Though I must say, most studies examined the 300 to 600 mg per day dosing range. A few went up to 800 mg per day, and one study which I saw in schizophrenia went up to 1,000 mg per day. If you're giving CBD for a long time, and particularly in a high dose, obtain CBD liver enzyme levels at baseline and monitor maybe once in 3 months. So that ends my presentation. I hand over to the moderator and to the panelists.
Thank you very much, Chitu. It was a short overview and excellent. You have covered most of the things in a, what do you call, an abridged version. And back to the moderator, Shobit. I will not comment on anything now. Shobit and the panelists are there. But Chitu, one point, especially Dravet syndrome, tuberous sclerosis complex and other thing, they have seen it in the intractable seizures after raising 25 milligram per kilogram per day, then it is not effective. Then you have to titrate down. How this happens, they don't know. But still, intractable seizures, 40%, they have responded. And 40%, something is better than nothing, especially in Dravets. Especially my friend Vinay and Amrita Hospital Pediatric neurologist, we had a session with him. He was suggesting he has got some experience on it. I mean, this is a suggestion, but in adults, it is 300 to 100 milligram per day, 150 to 300, absolutely fine. But very difficult to say it is only cannabidiol because, as you have rightly told, endocannabinoid system 150 plus is there for the time. Well, now it is around 150, this thing, 120, now 120 plus, but we do not know what all things are there apart from THC. The major ones are CBD, then cannabinol, cannabidiol, like that, and the minor version. Even to do the studies also, it is very difficult. We are focusing only on that. So we do not know, especially RCTs and everything you have mentioned. You have already told about the number of studies and number of clients. Very few. And you have suggested some of the journals like AGP, JCP, etc. It has also been reviewed, even systemic review in psychiatric research. Then the recent ones are coming only in curious therapeutic advances in psychiatry and therapy. I mean, plenty articles, but very difficult for us to digest how we can use it. And your last line of your suggestion, more RCTs have to be done in our population using the cannabidiol 99.9%. Then see whether it is going to be effective or not. Also, mind you, the cost factor. And you have already talked about the cytochrome enzyme interaction. Wonderful. Now back to Shobit.
Yes, sir.
Shobit, it is your
I think a lot of questions are coming up. Fantastic presentation, sir. Sir, I'll just start with few things which I want to ask from my side. That so you have mentioned very interesting thing that CBD would actually inhibit the metabolism of THC. So in this sense, then there have been some data that CBD can actually potentiate the psychoactive effects of THC when not given in similar proportions. So wouldn't then how it will help us in this cure or addressing cannabis dependence in that sense?
To whom is this question addressed?
It
For
is
you.
to you.
Yes, sir.
Well, there were two studies which looked at CBD and its effect on the metabolism of THC. One was published in Psychopharmacology, Berlin, about 20 years ago. The other was published in JAMA Network Open last year. And both studies found that CBD increases the action of THC. And the explanation given was CBD inhibits the metabolism of THC, thereby leading to an increase in the bioactive effects of THC. So, if you're asking me how does CBD in combination with THC benefit patients with substance use disorders, including cannabis use disorder, I'd probably look at it like, for example, buprenorphine or methadone reducing the symptoms of opioid dependence. So we are using a lower dose of THC in order to reduce the dependence, the withdrawal symptoms. It's like treating alcohol withdrawal by giving lower doses of alcohol. It actually works. Of street cannabis and use cannabis instead of street and use, for example, methadone or buprenorphine, having
Sir, I think we have lost your connection again, sir.
Chitu, you are mute. You are mute. Chitu, you are mute.
So I don't know how that happened. I didn't mute myself. Anyway, I think you would have heard my answer anyway, right?
Yes, yes, yes.
Yes,
But
yes.
Chitu, these are all many concepts, very difficult to buy it because I also gone through this, very difficult to tag it. But the most recent one with the CBD is it activates in the 15 lipooxygenase enzyme. That is why the anti-inflammatory properties. And also previously, many orphan receptors are there, especially G protein couple receptors, multiple varieties, especially CR55, 119, and GPCR 18. These are all coming way to explain some of the substuff. I mean, we will not go into the molecular details. Shobit,
Yes, sir.
you can.
And very interestingly, sir, I went to the Epidemiologs, sir, from the US, where the very higher proportions of infections were proposed, predominantly skewed towards pneumonia, chest infections. So this being an anti-inflammatory mechanism of action and such a skewed proportion of infections, probably we need to see it in our setup and our experience with the drug. So I'll come to each and every panelist, and subsequently the set of questions will be probably addressed via them, and then they'll bounce to you, sir, if they're not addressed. So I'll invite my dear friend, Dr.
Sorry, may I just chip in for a minute here?
Yes, sir. Yes, sir.
When we speak about adverse effects, just keep in mind that a lot of the data on adverse effects were actually obtained in children with seizure disorder.
Right, sir.
So if we are going to be prescribing it for adults with psychiatric disorder, we do not necessarily need to see the same profile of adverse effects.
Right, sir.
Okay, please go ahead.
So then, so with this, I'll invite Dr. Priyaranjan Avinash. Sir, he's a dear friend of me. Priyaranjan has a very good interest area in forensic aspects. So can Priyaranjan, can you help us in detailing about the legal aspect, the prescription status, any specific registrations required? That is being questions spotted in the chat box. Priranjan, please.
Yeah, thank you, Shobit, for the question. And thank you, Andrade sir and Mohandas sir, for opening with such good presentation. So large part of the question that you raised, Shobit, has been already covered to some extent, I believe, by Dr. Andrade sir's presentation about the legality of CBD. But then I was reading about CBD and THC because I had to be the part of a panel of this particular presentation. So the NDPS Act speaks about cannabis, but recently, see, whenever there is a conflict, then we go into the whatever cases that are going on in either in the High Court or the Supreme Court. So they become kind of precedent. So the few recent litigations that was there in the High Court, one in 2022, where this Bangalore-based company, which is already marketing cannabis oil and various other cannabis products online, and also dispensing through offline clinic from 2020, which is now more than 3 years now, was one of the appellant. And the case was against it. So the government of India gave an affidavit at that time, including the narcotics control, director of the narcotics control, what called in the jurisdiction. And he said categorically that as long as the cannabis part contains only the leaf or the seed and resinous exudate, then it is not covered under the NDPS Act. That is a little controversial because when we read the NDPS Act, it doesn't so categorically speaks like that. Also, if you go by the Drugs and Cosmetics Act of 1945, 40 and 45, the regulations, there also in the Schedule E1, there is a mention of cannabis. And our Ayurveda friends, colleagues, have been prescribing various forms and products of cannabis from decades, or maybe I think from the beginning of the time. So we allopathic practitioners are discussing about the legalities of part of cannabis, whether it is just CBD or THC. But taking all of this into account, the NDPS, the affidavit given by the Government of India, recently many states, one by one, including our own state of Uttarakhand, has legalized farming as well as production of cannabis for industrial and scientific purpose, including medicinal purpose. So if we take all of this into account, all forms of cannabis, whether it is CBD or THC, if it is not in the form of charas, the resinous exudate, or not in the form of marijuana, then it does not come under the legal purview of NDPS Act. So they can be prescribed for both medicinal as well as it can be used for various scientific and industrial purpose. So this is my understanding. And I have read few documents to support this answer that I am giving you.
But we'll already be able to use it for approved indications as of now, not for
that is a different thing. When it comes to approval of indication, that is DCGI comes into the role. So DCGI has given 3 approvals only as of now in India. We already know about it, that Lennox-Gastaut and one more seizure condition, and then tuberous sclerosis complications. Madam Sashmita will highlight that further. And these are the 3 indications. But that is about approval. So there are 2 different things, legality and approval. Now, many of the clinicians may be a little bit wary about prescribing drugs which falls into little bit in the gray zone. Now, in that case, what happens that if for example, let's say you prescribe cannabis in some form and you can be taken to the court. Somebody can interpret it as against NDPS Act. Then in that case, what will happen? Who will come to your rescue? So there are volume of evidence. The Government of India's own affidavit in the High Court of Delhi will come as your kind of defense, as well as your colleagues. Now, we all know the law, like how it works. So as well as your peers and colleagues, if they support the international documents almost all over the world, including European and American world, various forms of cannabis is being used for medicinal purpose. Now there is a debate, as Andrade sir has rightly mentioned, whether only CBD is good and THC is all bad. We know that it is not like that. It is not so black and white, that CBD is all white, THC is all black. Rather, there is a movement in the Western world about taking the whole cannabis. And it says that the whole cannabis effect is better than the part effect of the cannabis. That is called the intras effect. Many of us are familiar with that. So there is medicinal part, there is a recreational part. As far as India is concerned, the recreational use of cannabis is not allowed, but bhang can be used even for recreational purpose as far as India is concerned. That is again according to the NDPS Act as well as the Government of India directive.
So I think Avinash, you have answered this vividly, but we are not 100% foolproof. Legally protection we can derive by prescribing this. This is something we needs to be debated further. And that is your take on this.
You're asking me about the legality of prescribing CBD?
Yes, sir.
It's absolutely legal. I don't see any issue with prescription of CBD. Once it has been approved in India, it has been approved for use for 3 different seizure disorders: Lennox gastaut, Dravet's, and tuberous sclerosis, seizures associated with these 3 conditions. And these are on-label uses. Off-label, if we use on paper, if we can justify it, as pointed out by Dr. Avinash, on paper, if we can justify it based on research literature, we will not be questioned. Off-label prescription occurs all over the world. It even occurs in the USA, and off-label prescription is even reimbursed by insurers in the USA if there is literature available supporting its use. You take a lot of the drugs that we use today, for example, trazodone for insomnia, quetiapine for insomnia. We use amitriptyline for irritable bowel syndrome with hypermotility. These are not actually approved indications. If you look at the label for amitriptyline, it will say depression. If you look at the label for trazodone, it will say depression. But we're not using these drugs now to treat depression. And nobody's coming after us, right? We can justify the use. So legally, off-label prescription is happening everywhere, and legally off-label prescription is supported by peers and by research.
Right, sir.
It would also help if we have a good relationship with our patients. If we rub up our patients the wrong way, for example, they're more likely to take us to court. And if we are prescribed something that is not on label for them, they will be a little more aggressive with us. So there are a lot of things that we should keep in mind when we are prescribing drugs off label. I think we can prescribe off label with caution. We should not be reckless in prescribing off label. We should not go beyond what is, say, described in research studies.
Right, sir.
I'd like other opinions on this also, because this is a potential issue.
So Boland's principle might also help us in this context. Sir, I'll also now invite Professor Dr. Sasmita Devi Agarwal. Ma'am is a pediatric neurologist in our panel and epileptologist. So, ma'am, your take on the usage, the approved indications in this pediatric epilepsy. I wish that you would have used this molecule more than more than us in the panel, and your experiences regarding it, ma'am.
Thank you very much. Thank you, Intas, and thank you, Dr. Sovit, for this introduction. And this is a nice question, actually. Sir has already explained and also is nicely told about the indication in cases of epilepsy, that is Lennox-Gastaut syndrome and Dravet syndrome and tuberous sclerosis complex if the child is more than 1 year of age. So I have if I will say the and in some case, some refractory epilepsy cases also of unknown etiology, we don't have the we don't know the etiology, but they are not responding to the common anti-seizure medication. In that condition also we can use cannabidiol. Okay, if I will share my personal experience, I have used in some cases of Lennox-Gastaut syndrome. And Lennox-Gastaut syndrome, it is a syndrome complex which is characterized by multiple type of seizure with a developmental delay and a characteristic EEG finding. Okay, a characteristic EEG changes during the awake and a characteristic EEG changes in the sleep. So if the triad is present, we can diagnose that it is Lennox-Gastaut syndrome. But if you look at the etiology of Lennox-Gastaut syndrome, it is multiple etiology. It may be due to the congenital malformation of the brain, and it may be due to neonatal hypoglycemia, it may be due to HI, hypoxic ischemic encephalopathy, or it may be due to any trauma to the brain, or it may be due to the genetic mutation. If you look at the etiology of Lennox-Gastaut syndrome in our country, I think worldwide, the commonest cause of Lennox-Gastaut syndrome is HIE, perinatal insult, either a neonatal hypoglycemia or a neonatal hypoxia. I have tried few cases of Lennox-Gastaut syndrome with neonatal hypoglycemia as a consequences of neonatal hypoglycemia and HIE. I have not used in the genetic condition. I think they are responding. One case, that was a case of posterior reversible encephalopathy syndrome. The baby was absolutely fine till the age of 1.5 years. Suddenly, he developed hypertension and developed posterior reversible encephalopathy syndrome, PRES. And later on, he developed the Lennox-Gastaut syndrome, the unknown etiology. Etiology is not known up till now. I did the genetic test, genetic is negative, and there is a small gliotic changes in the MRI. In that particular case, it is a dramatic response. I started with 5 milligram per kg per day. I mean 2.5 milligram per kg per dose, BD divided doses, 5 milligram per kg per day. And in the first week, with a normal liver function test, and the second week, 10 milligram per kg per day. I mean 5 milligram per kg per dose in BD dose. And after that, 10 milligram per kg per day, the child responded very well. There was a lots of drop attack. The main complaint for this particular case was a lots of drop attack. Okay, and because of the drop attack, there was multiple head injury. I mean trauma to the head. Okay, and after this CBD oil, the right now the child is completely seizure free, this drop attack free, and I am very happy to share that he has started to go to the play school since last 1 week. So
This
this
was
is
first.
about one case. This is about one case. Some other cases also there is a reduction of seizure frequency definitely. And I have not used up till now in cases of TSC, tuberous sclerosis complex. And in one cases of Dravet syndrome, there are some response. So my experience with this cannabidiol in Lennox-Gastaut particularly is, and it was due to some, I mean, perinatal insult, except in one cases that is of unknown etiology. Rest other has good response.
This was in monotherapy, ma'am, or in polytherapy,
No,
ma'am?
no, polytherapy. So before CBD, the child was having 5 anti-seizure medication: valparin, clobazam, zonisamide, topiramate, and also he has received once or twice, particularly this case. Once, I think twice, he has received omnacatil steroid. Okay, but when he came to me, he was in highest maximum dose of sodium valproate, clobazam, topiramate, and zonisamide. So at that time, CBD oil was not available. I started omnacatil again because there was a lots of seizure episode, lots of tonic seizure and drop attack. So I restart the steroid again and started the ketogenic diet. There was some improvement, but not to that much. And luckily, by that time, we got this CBD oil. And in this particular case, the baby is seizure free, drop attack free since last 2 weeks. He has completed 1 month, and he is doing well. I stopped topiramate, and I stopped jonisamide also. Now he is on valparin, I mean sodium valproate, clobazam, ketogenic diet, along with this CBD oil.
I think
So
very
most of
interesting.
them, in most of the cases, they are drug-resistant epilepsy only. We will go for the first line. See, if you see the price of this one, CBD oil, it is too high. If the weight of the child is somewhere around 15 or less than 20, it will be affordable for the family, they can afford, they can think of starting this medication. If the weight of the child, today I saw a child who is 35 kg. So they asked me, "Ki, Madam, this new treatment, shall we go for this one?" And when I calculated, it is hardly 160 ml bottle will go for 2.5 to 3 weeks. So it is very difficult for them. So if the weight of the child is less than 20 kg, preferably somewhere around 15, definitely it will, the parents can afford for a long run, and they can think to start this medication. And definitely before starting CBD, we will start the common anti-seizure medication for that particular seizure or that particular epilepsy. Then we can think of CBD oil.
A very interesting, ma'am, sneak peek into a very interesting case scenario. And that is, sir, there is a question regarding the percentage of response of cannabidiol in Lennox-Gastaut, Dravet syndrome, and its role in medial temporal lobe epilepsy.
Sorry, this is out of my area of specialization. Dr. Sasmita may be in a better position to answer.
I don't have the exact data actually to say.
Let me put it this way. I don't think we can expect the patient to be completely free of seizures. The vast majority of patients may show some decrease in seizures, but very few will be completely free of seizures.
And
No, there are some. There are some
literature.
data actually. There are some data available actually. There are some data.
Literature.
Yeah.
These type of syndromes, intractability is there, but those people, 40% respond. I mean, that 40% in intractable one, it is a blessing, right? And others, you are told that other type of seizures, even if you put it offline, better to get a consent, because cannabidiol has come and got rapid approval of, fast track submission approval, not by the doctors, it is by the public. And the people have even pressed on it the benefits. That is how this research has come. You can go through the literature, you can get it. That is what is happening around the world. The literature suggests 40% respond only in intractable, including Dravet, tuberous sclerosis, and nothing. Tuberous sclerosis, there is a jinx, the dosage is different. Anyway, I will not comment on it. You can go through the literature, time is not there. Okay.
Coming to the last panelist, sir, Dr. Vivek Pratap Singh. Sir, Dr. Vivek has an experience in child psychiatry and also in addiction psychiatry. There is a relevant question in the chat box, Dr. Vivek, about ADHD. And in any case, any role that it can act as a stimulant, and your take on it, and subsequently any role in subsequently other neurodevelopmental disorders.
First of all, my regards and pranam to Dr. Chitranjan Rajesh sir and Dr. Imon Das sir, whom we have grown seeing as a teacher, and being a panelist in which sir is an organizing person, chairperson, is a great pleasure for me. Coming to the part of child psychiatry, basically in child psychiatry, as ma'am told about, Agarwal ma'am, Shashmita ma'am told about that cost matters. Yeah, it really matters because we are in a lower middle income country group. If we compare the American data, to be a PA member, we are listed as LMIK country group. So cost really matters. So first of all, it was promoted as a anti-epileptic. Just somewhere I saw the pamphlet of ADHD and autism. That day I searched whole day about the different aspects where it can be used. And what was my primary point, that it should be cheap enough to show that the one bottle should at least go for 2 to 3 months, and patient should show a dramatic improvement. But without counseling the patient and without taking proper consent, I cannot write a syrup costing 15,000. It's a bit difficult thing. But my first point is that everybody, as I think, should take consent from patient. If the patient agrees, then only we can provide in child psychiatry, because there are many patients from lower middle income group who cannot afford. They directly tell, sir, hum nahi de sakte. Then we have to not think about cannabidiol. Three things which I have found is that right now, till now, Cannabidiol just it was launched in January or December it was launched. At that time, many of my ADHD or an autism spectrum disorder patient with ADHD were on normal methylphenidate, on arkamine. Moxinidine was used also by me to convert the arkamine to a less sedative form to be on the safe side. Valprol was using, Risdon was being used to just control the aggression lying inside. At last, when patient started showing some 60-70 improvement, I thought, ki, what to do for this 130% improvement? Because after that, I basically, people send the patient for therapy, and therapy has now just become like a grocery market. If you search for a therapist, there are a lot of therapists, and the public awareness is also much more on the therapist side, and much more that ADHD and autism are not curable, and it needs special training only, and no medication is there. What I have observed during my this 8-10 years practice, that if treated properly on methylphenidate as a first line, arkamine as a second line, then for aggression, valproate and risperidone or any other form, I even have used indoxafen, that is called Zonalta in this case, in which the patient is already very heavyweight. Right from that, I have also used Eslizen in place of Valprol in patients who are very fat. So when I got 70% improvement, then when I added, first I searched for the drug dose exactly. Never, I have found many articles. I think in one article only a bit appropriate dose was there, that 5 mg is the optimal dose, but I was a bit successful in this, in getting the right dose. That I read the right article that was from Lancet. I cannot share the details because I am not having right now. There it was written that till 5 mg per kg will get the response. So I took cannabidiol and separated it into 10 bottles, different bottles, and started doing the testing dose. And I gave the dose in my clinic and let them sit for 2 hours so that any reaction or anything should be there. If ever, should not be, the patient should not be misguided, or should not feel that he's being cheated because he has invested 15,000 in the medication. So I started giving testing dose, and in every next follow up I started asking कि आपको कैसा लगा था, वो दवा मैंने दिया था उसके बाद आपको कैसा लगा था. What I found is the most important part. From my part, till now, I have not used it as a first line treatment in the patient who has 70% improved and are indulged in the neuromodulation, the brain stimulation, the TCDS part, or any other things which the person can afford, the doctor can afford at his clinic, the machines of neuromodulation, along with the different speech therapy, occupational therapy. If we add a small dose of Moxilong, that will increase the attention part, and that will not produce any sedation or drowsiness like arkamine, that is clonidine, or moxinidine. That was the major part, and till now I have used almost 12, 13 in almost 15 patients. 6 have purchased and rest are on my testing dose. So till now I have got a drastic improvement, and patient mothers itself tells. And then after gaining this information, I started telling them to observe the other patients, and they also saw the same thing, only the patient was very attentive but no sedation was there. So that helped in the therapy part also, and in the treatment part also. So and in addiction part, in a very short, because I was mainly concerned with child psychiatry, and the age of the patient, the weight of the patient was almost maximum 15-20. So max they have to invest is 4 to 5,000 or 3,500 per month. So it's a very cheap option if used in child psychiatry. And second, the cheapest part apart from this, the addiction part. The addiction part, actually it was conveyed at last about the addiction part. I haven't used till now in the any addiction part, but according to the different thing, It modifies the opioid systems, the endocannabinoid system. It increases the anandamide levels. Also it acts on 5-HTA receptors, which just modulate the mesolimbic pathway, which controls the mesolimbic pathway, have some effect.
I'll interrupt you because of the time
Yeah,
constraint.
yeah, ma'am. Yeah, ma'am. Yeah, ma'am. Yeah, sir.
I think an
And
interesting figure which you have given.
two last things, sir. Glutaminergic system was just decreased, the glutamine release or decrease. And last, the most important, the hippocampal neurogenesis. These are only the 5 parts on which we have to work to control the patient of substance disorder as concerned to substance disorder. First is dopaminergic, second is opioidergic, third is endocannabinoid system, then the serotonergic 5-HT1A, then it will decrease the glutaminergic system, it will glutaminergic release, and last is the hippocampal neurogenesis. So I haven't used, so I don't have the practical implication and a practical thing for sharing about addiction. But yeah, I have shared important thing. I think about child psychiatry. Let's see what happens in the future. How the patient complies and how they be
So you actually
complied to the treatment.
very interesting way of actually blinding it and seeing the response of the patients. Sir, and that is, sir, I'll just the last two questions before Mohandas sir will give a closing remarks on the session. Sir, two interesting questions in the chat box, that whether CBD can be a gateway drug, the liability, abuse liability potential of it, and duration, apart from epilepsy, the experimental indications. So what should be the duration? I know these are this will corner you, sir, but please, your views on it, sir.
So, can CBD be a gateway drug? In my opinion, very, very, very unlikely. For the simple reason is that CBD does not have psychotropic effects. It's not psychoactive. For it to be a gateway drug, there must be some psychoactive feature that would make a patient recognize he's taking a substance with potential euphorogenic property or relaxing effect or some other effect which is very noticeable. CBD does not have these kind of effects. So we don't have to worry about CBD oil as marketed in India for seizure disorders that are refractory. We don't have to worry about it being a gateway drug. Your second question is on the duration of a CBD trial. I think it depends upon the indication. For example, if you're giving it for an anxiety disorder, we know pretty soon. If you're giving a benzodiazepine, we know within a week whether the benzodiazepine is helping the patient or not. If you're giving a tricyclic antidepressant, we know again within a week or two. If you're giving an SSRI, it would take maybe 2 to 4 weeks for an anxiety disorder. I think the CBD does not work through serotonergic receptors. It works through endocannabinoid system. You'd expect to see benefits much faster. So if within 2 weeks there are no anxiolytic effects, there is no improvement in sleep and so on, I think that would be sufficient to say that the trial has failed. But if the trial has succeeded within this period itself, we'll know. However, if we are giving it for a condition like, for example, psychosis, we need to give it for much longer. We don't expect to see refractory symptoms of psychosis disappearing in a week or two. It could take 4 weeks, 6 weeks, or even longer. So the duration of the trial would need to be even longer. So in a nutshell, how long should the trial be? It depends upon the disorder for which it's being prescribed.
Right, sir. So over to Sir Mohandas, sir. Sir, your comments, closing remarks on the presentation, and other questions we can actually ask and that is, sir, to address them. We can actually mail it to sir. And most of the questions sir has already addressed in his presentation. So I think with this,
Thank you very much, Rachitu. It was a wonderful presentation and many questions have been asked, but very difficult to answer because the research hasn't really gone into that. And only label indications throughout is only three, that is ledagestor, Travax, and tuberous complex. Others are all off-label indications. Now, somebody was talking about my friend in child psychiatry. There, if you see the literature review, you can go through the autistic spectrum disorder, cannabidiol, 2022, the Curious Journal, and you can go through schizophrenia, cannabidiol, oil in schizophrenia, advanced psychopharmacology and psychiatric research, 2020 and 2019, and neuropsychiatric symptoms of dementia, Alzheimer's, total triumphs in psychiatry and psychotherapy. This is also late 2021. But also in Parkinson disease, recent literature has come. But before people ask questions, I would advise all the people who have attended, you can easily go through Psychiatry Review, September 2023. Not Psychiatry Review, Pharmacological Review. You can easily get it. Similarly, Brain Sciences 2023, Molecules 2023. These are all easily downloadable now. You go through it, get the idea, then only read it. And I do have plenty of articles on in neurology, what has happened, because more than 40 reviews are with me, 40 articles are with me, which I have shared with my neurology friends when I was doing. That is one. So whenever you do in off-label this indication, worthwhile to discuss with your clients pros and cons, get an informed consent, and the cost factor. Otherwise, you will be sued. You have to keep it for the time being. Whether people are using it, yes, they are using Ayurveda. Chitu has told that. And I had an experience. Can I just take 1 more minute?
Yes,
I
sir.
had an experience of a client which was 18 years or 20 years back. He was a rider in the globe, that is in circus. He had a traumatic event. After that, he had intractable seizures. He was on multiple drugs. Then he started abusing cannabis. His seizures got controlled, and his only living way was only in circus. He asked me. I told that you live happily even with cannabis if the seizures are controlled. That was almost 20, 25 years back. The last point, legalization, 2 decades back in All India Institute under Devendra Mohan, we had a 4-day conference regarding the legalization of cannabis. If anybody is interested, they can contact. There are volumes of the thing we have addressed, and they are all there. You can go through it. And with Devendra Mohan, I have written Cannabis in Developing Countries. That is also almost 3 decades, 4 decades back. So, and Chitu has told the psychotogenic potential of cannabidiol is very minimal. And unlike THC, THC is a terpene. And he has talked about the enzyme interaction. You have to keep it in mind. I will not go into details because I am not going to give a lecture on it. Okay, thank you very much. It was a good session. And our neurologist, Agarwal, I met her sometime back when I came there. Mohit,
Yes,
is
sir.
a,
Yes, sir.
Mohit is a friend of mine, movement disorders. And at the time I talked on history of imaging or something like that. I don't remember. So anyway, it was a good session, good interaction. And Chitu has suggested we need more trial in India because cannabis indica contains it mainly cannabidiol. And the cannabis psychosis, the maximum one is reported from Morocco. That is the initial one. It was reported in India, in Indian Medical Gazette, long time back when we were writing on cannabis and cannabis psychosis. We will not talk that is because of THC and other related one. Half a dozen main endocrine system. Anyway, what wonderful session, good question, very difficult to answer all the questions because the literature is too scanty and we do not have an on-hand experience apart from anecdotal this thing. Okay, thank you very much, Shobit. Back to you. you can wind up the session.
What a wonderful learning experience, sir. Our therapeutic armamentarium is broadening, more to study, more to read, more to comprehend, and more to research. With this, I'd like to extend my heartful thanks to Andrade sir, Mohandas sir, my fellow panelists, and I think 350 delegates. I just got the message from the organizers, 350 delegates. So with this, I think I'll sign off. Good night, everyone. Thank you.
Thank you.
Thank you. Good night.
Thank you. Thank you, Chitu. Good night.
Thank you, everyone. Good night. Good night.
Avinash.
Thank
Good night to everybody.
Good
Good
night.
Avinash.